Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome back to another episode on the Health Trip Podcast, and welcome to Season 3. If you're a midlife woman, then your bone health should be at the top of your list to have properly assessed. As women age and transition from perimenopause to menopause to post-menopause and beyond, our bone health is at risk, for some more than others, especially if there's a family history there. Here's a stat from the Bone Health and Osteoporosis Foundation. Of the estimated 10 million Americans with osteoporosis, about 8 million or 80% are women. Approximately 1 in 2 women over the age of 50 will break a bone because of osteoporosis. A woman's risk of breaking a hip is equal to her combined risk of breast, uterine, and ovarian cancer. Let that sink in. Perimenopause can start for women in their 30s, and the average age for a woman to go into menopause is 51. So right there, you've got a possible 15 to 20 years that your bone health could be declining. In conjunction with declining and fluctuating hormones, let alone years of possible suboptimal lifestyle, nutrient deficiencies, poor sleep, on and on. Since our current healthcare model is not set up to prevent disease and health issues, it's your job to be your own self-advocate, especially when it comes to your bone health. One of the tests that I recommend for all my midlife women clients to get is a DXA scan, which is the gold standard for assessing your bone mineral density and risk of osteoporosis. Unfortunately, most health insurance companies will not pay for this test as a preventive measure until you are 65 years old, 70 for men. As an out-of-pocket expense, it's really not that bad. It's around $150 to $250. And you then want to be working with a doctor who is well-versed in reading the results to help you navigate any bone health issues that you may have with lifestyle, diet, supplements, and possible medication. So you don't need a doctor's script to go get a DXA scan, although if you want to get it covered by your insurance or at least try, then you definitely do. I've invited back Dr. Christy DeSapri for another episode to go over what a DXA scan is, how it works, how to read the report, and then what steps to take next, if any, are necessary. So we're going to use my very recent DXA scan that I'll pull up. And so if you're listening to this podcast, I suggest that maybe you hop on over to my YouTube channel at Jill Foose Wellness to watch this podcast. Dr. Christy DeSapri is a board-certified internist specializing in midlife women's health. After fellowship training at the Cleveland Clinic, she has worked in private practice and academic medicine for over 13 years, including being the director of the Northwestern Women's Bone Health Program at the Center for Sexual Medicine and Menopause at Northwestern Medicine in Chicago. She is currently opening Bone and Body Women's Health, a concierge midlife women's health practice in the Chicago area focused on consultation and management of perimenopause, menopause, osteoporosis, and sexual health. A short little medical disclaimer before we dive in. By listening to this podcast, you agree not to use this podcast as medical advice for making any lifestyle changes to treat any medical condition in either yourself or others. Consult your physician for any medical issues that you may be having. And this entire disclaimer also applies to any of my guests on my podcast. So sit back, open your minds, and let's dive into DXA scans. Hi, Dr. DeSapri. Welcome back to the Health Trip Podcast.
Hi, Jill. How are you on this snowy day?
Yeah, it's pretty cold out. We're both located in Chicago for those of you tuning in, and we are sub-0 degrees out right now. So it is a perfect day for a podcast.
That's right. No better time to talk about DXA body composition in the
Right.
winter when we're all thinking about the summer.
Yes. So we did a podcast last season and we talked about bone health. Was one of your specialties. And we went really deep into why bone density changes even occur as women age. We talked about options that are available to support osteoporosis. So I encourage everyone listening, if you haven't checked out that episode, go back to season 2 and look that one up. So today we're going to do something really fun and different and interesting, and we're going to dive into my personal DXA scan. And for those of you who have never heard of a DXA scan, you have no idea what we're talking about. That is why we have Dr. DeSapri here. So let's first just talk about this test and all of the special nuances around it.
Okay. Well, I think first, when we think about DXA, DXA, I think it's always important. Let's start at the beginning, right? So what does that stand for? What does this measure? And where do I get it? I mean, right? The what, where, when, why, and how.
Right.
So I think that so DXA stands for dual energy X-ray absorptiometry. So DXA is actually a glorified X-ray of certain areas of our body. Primarily, we scan the spine as well as the hips and sometimes the forearm. And what we're looking at is we're looking at the BMD or bone mineral density. So sometimes the DXA is also called a BMD study or a bone mineral density scan. And that actually, if we look at the bone mineral density in those sites in the spine and the hip and sometimes the 1/3 forearm, that estimates bone strength by about 60%. So that's why when we're looking at our density and our strength and understanding our risk for a fracture, and we'll get through how all those, sort of are combined in a minute, that's why we use the DEX as a screening test for prediction of low bone density, osteoporosis, and then subsequently our risk of a fracture. Not all low bone density causes a fracture. Not all fractures are caused by low bone density. It's important to know that. But when we look at a screening test, that's what we're looking for, capturing women and men who are at low risk for fractures due to a low bone mineral density. A DEXA is a low radiation. It's 1/100th of an X-ray. It's about the same amount of radiation as you would get just like walking around in a day. So it's a very low. It's less than 0.01 millisieverts. So really don't need to be concerned about that. You generally, most places have you undress or wear no metal, including no like belly button piercings or any other metal when we're doing that, like belts, bras, etc., to get a good standard scan of the spine, generally the lumbar spine, and then the hip scan at the hips as well, and then sometimes the forearm. So lots of valuable information that we can get about bone mineral density, and we'll talk about some of the other things we can do with DEXA if we choose to as well.
Yeah. So who's a good candidate for this test?
So I think that just depends on who you ask. Good candidate, I think it depends on whether you ask, the medical societies, what sort of information we have that's been validated versus, when we think about looking at prevention. So I know you and I are both focused on more on prevention. I always say prevention is the best cure. So when we think about bone mineral density, we know that, and we talked about this in our first podcast, that women at menopause are going to lose up to 20% of their bone mass, primarily in the spine or in the trabecular or femoral neck compartment of their bone density. That's why you see those numbers look sometimes a little bit lower than our total hip T-score or our forearm T-score. So when we think about menopause, that can happen at many different ages for women. That can happen at surgical menopause. It could be early menopause, premature menopause, natural menopause at age 50. Most of the medical societies say that if you don't have any risk factors, you should have a DEXA at 65. Most, gynecologists, most people in the menopause world, most people in the prevention world really feel like that's way too late.
Yeah.
And many women have risk factors for bone loss earlier, just being female, low body mass, Asian or Caucasian ethnicity, having a family history of osteoporosis or fractures, having a history of any malabsorptive issues, having any medical what was I going to say? Medical complications or conditions that might lower your absorption of calcium, vitamin D, or increase your risk for fracture. Things like steroids, cancers, aromatase inhibitors. So many different types of conditions can increase your risk. So it's important to know that earlier. And we know that just some women, genetics, plays a role. So 70% of our bone mass is inherited. So many women I
Mhm.
see have lower bone mass due to things that happen before menopause that we need to, or just genetics. So many women should have a DXA at the time of their menopause transition, whether they're 40, whether they're 50. And for many women, that's really what should be done. And we know from good evidence that that helps, again, predict future fractures. And if not, predict future fractures, it helps us understand what can we do to prevent osteoporosis, to prevent those
Mm-hmm.
fractures in our subsequent decades of life.
Yeah. So you were talking about the age of 65 and that the most health insurance won't cover this unless you are 65. I think it's 70 for men.
Mhm.
So this is not a high cost test. I mean, it's not dirt cheap, but it's certainly attainable for many people. Um, so when we're talking about perimenopausal and menopausal women going to get this, do they have to have a doctor's prescription to go get this, or can they just go get it?
Yeah. So at this point, again, I'm a physician, have my own practice. I really felt this is such an important area that I, have a DEXA scan here in my office to make that accessible, to make the results accessible, to explain those, to really come away with not just a piece of paper that says, what is this bone mineral density? What's a T-score and a Z-score? But really, what does this mean for me? What does this mean for my risk of fracture? What does this mean for me now? How can we, change this in the future? But most women, like you mentioned, peri and menopausal women need an order if they want to get that at a hospital or, a location, a freestanding radiology center from either, their internist or gynecologist or their, subspecialist to get that. So a medical order to get that. And there are some, ways that we could be creative. Yes, screening for osteoporosis is a diagnosis, but if you have a family history of, or any of the other conditions that I just mentioned, that is all a reason to get a DXA, and then insurance should cover those reasons. If you've lost any height or already had a fracture, already a DXA should be automatically done. And unfortunately, we're not doing enough of those. Um, and then in terms of other DEXAs, at freestanding places, a commercialization of DEXAs is now happening mostly because people are more concerned about their body composition, understanding what their fat mass is, their free fat mass, their skeletal mass. And so that also provides a total body bone mineral density, but very often does not provide the nuanced details of looking at the hip and the spine separately or looking at the bone quality. So you absolutely can get a DEXA in the hospital or a radiology center or in some of these commercial places that are offering DEXA, but mostly they're offering that for body composition, not so much looking at the bone mineral density or your risk of a fracture. Again, we need to move osteoporosis to the forefront and have that be more attractive and more and something that we care about on the inside. We care about our bones on the inside, not just external appearances and not just, fat mass.
Yeah, absolutely. And how often should women have this test done?
So that also varies, based on your age, your risk factors, your risk of a fracture, if you're on treatment. The answer from, insurance companies is that they'll cover a DEXA every 2 years or so, 2 to 3 years if you have osteopenia or something we call low bone mass or osteoporosis. Women who are on treatment, generally that should be done yearly. So if you're on a treatment to see if you're reducing your risk of fracture, whether that be hormones, whether that be, an osteoanabolic treatment, whether that be one of our anti-resorptive therapies like bisphosphonates or denosumab, really that should be done yearly or every other year. I find, again, why I invested in this therapy is that I think that it's really important to get accurate results, done consistently. And so for my patients, I am doing DEXAs, yearly.
Yeah.
The patients I see are at higher risk as well and are trying to be very preventative, and I endorse all of those things.
Yep, for sure. So you were talking a little bit about body composition and that can also show up on a total body DEXA scan, right? But let's talk about the difference between a DEXA and then maybe one that's very popular called the in-body, which are at a lot of gyms and a lot of people who are especially on weight loss journeys, or maybe they're working with a trainer and they check in every 3 to 6 or 9 months on an in-body. Let's just clearly go over the biggest difference.
Mm-hmm. So to date, right now, we've been talking about bone mineral density as looking at the strength and looking at the
Mhm.
bones, like really looking again at the bones. We know that a DEXA is actually the gold standard for also looking at our body composition, because when we look at the bones, we can also do something called and this can't be done on every DEXA, I should say. when we have a whole body DEXA, we can look at the, the bone mineral concentration or calcium, or content, I should say. We can look at the fat mass. We can also look at the muscle mass. And so that body composition on most standard DEXAs, whether it's a hologic DEXA or a GE Lunar, which I think is what you had done on a GE Lunar scanner, that takes about 7 minutes or so. So longer than, or different than the scanned sites that you're doing when you're looking for bone mineral density. And so this is, done routinely with you laying still and evaluating all the different areas of our body. And it kind of, again, calculates that free fat mass, the lean body mass, and the bone mineral calcium. And then it gives us a report with all those things, and it calculates special things like your android to gynoid ratio and your appendicular lean mass, and some of these things that we'll touch on. That does not routinely just come when you do a DEXA for a bone mineral density for screening for osteoporosis or osteopenia. And unfortunately, at large academic institutions, there's really no diagnosis code that we're using a DEXA for these testing. So that's where we're seeing, again, more commercialization of things like a use of a DEXA, which I think is the gold standard. And then there are other tests that have been done. You remember this from your time, is that we used to measure fat mass by using calipers. Remember when that was done? I think someone tried to measure, like I went to it, like I went to a gym, I think after a pregnancy or two, and they tried to measure my fat mass, like using calipers. I think I was like 2 months postpartum. I was like, I'm absolutely not doing this. Like, what are you talking about? Like, I'm here so I'm not like, don't start peeing my pants. Like, just a joke here aside, but like, again,
Yeah.
we have to think about why we're doing these things. And I know you touched on, looking at, making changes in weight loss or making changes in resistance exercise and skeletal mass to help us along the way. So this is why we're doing these tests. The InBody is the name of something that is just a bioimpedance. I have to look at the name because I always don't want to mess it up. A bioimpedance analysis, which is basically measuring electrical currents through our body. They travel at different wavelengths through water, through different types of tissue like fat and muscle. And so it measures, I think you hold on for like 2 minutes and it sort of measures that. And again, this is a rough estimate because it's, again, measuring the water content, electrical activity. It's an indirect measure. Just because it's simple and easy doesn't mean it's the best way. So it's one way, I think, that's becoming more widely available because people are looking beyond the BMI or body mass, index, which again is sort of a quick and dirty number that we're moving beyond. And so body composition does have, good data behind it. There is a database, the NHANES, which is the National Health and Nutrition Examination Survey, which is reviewed by the CDC and sort of validated, has 20,000 subjects from 8 to 85 years old. And they have this peer-reviewed, database for body composition as well as for bone mineral density. So again, this is where the DEXA has more validity, more reproducibility, I would say also, more accuracy. And even the ISCD, which is the International Society of Clinical Densitometrists, is what people who read DEXA appropriately, this is a training, this is certification, this is an ongoing certification, hours of time. They have also adapted this NHANES database for the hip as well as for body composition. So I would really, if thinking about the gold standard, we're thinking about the DEXA. All these others, calipers, bioimpedance, the bod pod, some of these other things, sure, they're out there. I don't think the validity is quite there yet, though.
Yeah, I think they are helpful, though, if you're someone who's on a weight loss journey and you're not going to go get a DEXA scan like every 3 months, right? You're just not going to do that. But jumping on an InBody, if it's available at your gym, might be a good way to just sort of monitor your progression.
Yeah, I mean, I think, again, people, we know this. We know from when we put someone on cholesterol lowering medicine, we want, positive validation. And I do think that, sure, I mean, I think if we're making lifestyle modifications, that can be helpful. I just think, again, when we think about the gold standard of looking at body fat mass, and specifically, we also have to remember that we have to look at that by, age and weight. Like we're talking, many of my patients, I know you see a wider range, but most of my patients are women in their, 30s through 80s who, again, are going through menopause, having other, we know that at menopause, there's shifts in, subcutaneous and fat tissue and fat mass, adipose tissue around the, the abdomen or organs, which increases your risk for so many things: obesity, metabolic syndrome, cardiovascular disease. We know that so much so that the American Heart Association really has put menopause as one of the risk factors for heart disease,
Mm-hmm.
not just biologic aging, but menopause is one of the times. And we've seen that, time and time again. Now we're finally starting to understand and realize that this is menopause. We need to take action and take note both in bone and cardiovascular. And again, maybe if this is one way that we can be doing that by tracking body composition.
Yeah, absolutely. So before I bring up my scan, I want to also just bring up sarcopenia in the
Mhm.
relationship to osteoporosis. And I think this is a bi-directional relationship that between the two. So if you could just speak about sarcopenia and how it differs from osteoporosis, but how it's also connected.
Yeah. So I think this is a term because I think we're becoming more aware of like skeletal mass, muscle mass, fall risk, predicting these things, how our chronic medical conditions, even like cancer, contributes to things like cachexia or weight loss or muscle wasting. I think these things are all pointing to the fact that we know that there is, like you mentioned, an intricate relationship between muscle and bone, sort of like you said, a bidirectional. Because of course, when my patients ask me about resistance exercise and things, I say, right, what's going to impact the muscle is going to also impact the bone, right?
Yep.
The muscle is going to be supported around the bone and vice versa. And strong. We know that when we measure studies that measure the vastus lateralis, which is basically a term for, your quadricep muscles, when we look at with the diameter and the width of those muscles, that also predicts, disability and falls. When the muscle is thin and frail, there's a higher risk for falls, fractures, disability. So sarcopenia is really a medical term that is that really brings together loss of muscle or skeletal muscle and loss of function. So whether that and how we measure sarcopenia is also evolving in the medical literature. Really, we can measure, sarcopenia by loss of muscle, but it also has to be function. So that's either grip strength or muscle strength in the thigh, push out strength, something like that. I mean, it's not rocket science, right? We know when we age, and we know that every decade of life we're going to be losing muscle mass. And then if we increase our risk for falls, and then we increase our risk for fractures, these things go hand in hand. Chronic medical diseases as well
Mm-hmm.
contributing to that. So I think they're both very important, continuing to think about muscle, bone, falls, balance, because when we look at the overall, risk for falls, remember, I just said the bone mineral density makes 60% of our bone strength and helps us predict who could fracture. But then there's all the other things, right? Lifestyle, balance, fall risk, all these other things that contribute to an overall fracture. So one part just can't be the answer, right? We need to think about it in totality. And so I think more people are thinking about sarcopenia, prevention of sarcopenia,
Mm-hmm.
talking about muscle mass, especially when we think about, I know I'm getting a little off tangent here, but when we think about things like our GLP-1 agonists that are helping with weight loss, if we're just going to lose fat mass, are we going to lose skeletal muscle mass at the same time? Well, that's not going to be good for us, right? Because
Right.
we're not loading the bone, and that's bad for bone mineral density. And we know that from, our studies with gastric bypass patients. So I think it's really an evolving area, and the fact that we need to be a little bit better at measuring sarcopenia. So this is where the DXA can sometimes come in, and we look at the muscle itself, but we need to look at the function of the muscle in addition to when we think about sarcopenia.
Yeah, and sarcopenia historically has been the disease of the elderly, right? It's that great grandparent of yours that's in a nursing home who has zero independence in terms of their lifestyle. And we know that it's starting to be found in younger women, like starting in their 30s now, which is a little nuts.
Right. I mean, when we think about exercise, right, and what we're recommended, I think there's always shifts in exercise patterns. And I think we're
Mm-hmm.
now in one that is maybe putting science a little bit better, in terms
Mm-hmm.
of doing some resistance exercise. It's not all about the
Mm-hmm.
numbers and the scale. And this is where body composition,
Right.
matters, strength. And again, remember, women are living longer. The average lifespan,
Yep.
women are living a third to half of their lives in the menopausal years. And so, right, we want to prevent fractures. One in two women fall over the age of, or sorry, 1 in 3 women fall over the age of 65. 1 in 2 women over the age of 50 have an osteoporosis related fracture in their lifetime. So those statistics are grim if you're going to live over 50. So we have to do the things before those ages that are going to prevent the losses. And sarcopenia, muscle loss, I think, that starts to decline around the 70th decade of life. So you
Yeah.
just mentioned that patient, the old elderly, super, in their 80s or 90s, we want to be like the super agers. We want to be preventing those things. And I think, again, the messages of prevention sometimes don't, are not as pervasive as some of the, oh, just we could treat that later. We could treat that later. But sarcopenia, we don't have any treatments for that, right? We have treatments
Right.
for osteoporosis, but we don't have any medical treatments for sarcopenia. We have nutrition, understanding about, protein intake and things like that, but we have no treatment for that yet, except for lifestyle, exercise, and treatment of the conditions that you have to prevent worsening of that.
Absolutely. This is why having that greater vision of what you want your life to be in your 70s, 80s, and 90s really comes into play. Working with someone like myself, national board health coach, and there's over 10,000 of us now. We're there to help bridge that gap between that diagnosis or that greater vision in real life. How are we going to put this into play, starting with smaller steps so that they can achieve success? And sarcopenia is huge. I give presentations on this all the time. What is that greater vision? Do you want to continue to go to the farmer's market at age 83 and carry back your bags of groceries or your produce by yourself, right? How important is that to you? So really thinking about that longevity component is really important, just as important as looking at this hard data. So
Mhm.
I've brought up the total body composition. So let's go through tell us what are the big things here to look at?
Yeah. So every scan is a little bit different in how they lay everything
Yeah.
out and
Yeah.
how you're going to see your body. But, you know, um, you know, so again, and I don't know if you want to first maybe click on the person, because I think that's like what I kind of think is easiest to understand from this, from the start.
Yep.
So what are we looking at? So we say a total body, like literally we're looking at your total body. So we're looking at the bone, which in this case, and every scan will be a little bit different. I read hologic scans, so the bone is a different color, but you could see, the bone is in, white, and then the lean is in orange, and then the fat, which you have very little of, it's in the yellow. So that's sort of where we see, and that's where we'll see. Obviously, the bone is going to be where we always see the bone in our pelvis and our legs and our arms and our clavicle, and our skull. And then we're going to look at our lean body mass. So we want to see that obviously in our lower extremities, upper extremities, around the hip area. And then where we're looking at fat mass is primarily, again, in the android area, which is the area around the abdomen and organs, and then gynoid area around sort of like the hips area. And so many women will have different distributions of where you can see that. But I think it's really helpful just to see that outright. Like, okay, what are we looking at? Where are we looking? What regions do we have? And then if you go back to the report, perfect. And so again, we're focusing here on, mass and lean mass and everything. So this is going to tell you obviously your weight and your total mass, and then your total body. So the things that I would focus on are what they're sort of listed at the top here. So your total, body fat percentage. And so that is the number that really, again, when we exclude the lean mass and we exclude water, and we exclude the bone, what is the total body fat percentage? And that really is sort of on again, a continuum based on the NHANES database. Ideal body fat for women, again, in a body composition, not BMI, is between 23 and 33 percent. So again, lower body fat is, again, can be ideal if you have more skeletal mass and skeletal body mass, but that's generally what we're recommending for most peri to postmenopausal females. And then we can look at
Say that range again.
It's 23 to 33% is what's
Okay.
considered within normal.
Got it.
Again, based on the NHANES database
Got it.
of women, and it's different for men, etc. And then if you were to add up, you can see across the top here, your total body mass, your fat mass plus your lean tissue, plus the bone, that's going to equal, your weight. So that's how you get you get to that, that's how you get to that number. And even when you look at the fat-free mass, again, the 98.6, so that's the mass that is, fat-free mass. So you have a very high level of skeletal muscle in your body. And I'm sure, I don't know if you've done the InBody, but if this correlates,
Yep.
pretty nicely to that as well. And then sometimes you could see it track changes a long
Mm-hmm.
time. So,
Yep.
so that's what I look at. So again, to body fat percentage, and think about that your age and your demographic, your free fat mass, again, the total percent of lean tissue and bone mineral calcium. Make sure all those numbers equal up to the total mass that you are weighed on that day. And so that can be pretty helpful. And again, I think I reviewed that, with the picture. I don't know if the last
Oh,
page.
wait,
Go
I wanted
ahead.
to ask you one question. So is there a certain is there a certain amount of your lean mass that should show up on here in terms of there's an equation. All right, let me back up here. There's an equation you can use. It's 100 minus your total body fat percentage, and that gives you your optimal lean mass. And so I've done a lot of studying on that number, and an optimal number is 70 to 90% of your lean mass is where you want to be. So for me, it'd be 100 minus 18. So it's going to give me around 82. So I fall within that 70 to 90% of that optimal range.
Mm-hmm.
Have you heard about this equation to
Yeah, I
use?
mean, yeah, there's a lot of different equations. I mean, I generally look more at the visceral, I don't know if it's on yours, but like the visceral adipose tissue, which is again the adipose tissue around the organs, because I know that that is more validated in terms of risk for the
Mm-hmm.
conditions like obesity and metabolic disorder and cardiovascular disease in women. So I look at the visceral adipose tissue. Yep, I think you have it here, and it's
Yeah.
the hormonally sort of active, fat tissue. And then I also look, at the android to gynoid fat distribution, and in women that should be less than 0.8. Again, so these are all looking at, different areas, particularly the ones that you can see from this, this picture here. So your visceral adipose tissue, does it say? So your AG ratio is well under 0.81,
Mm-hmm.
which for women is, concerning. And then, yours is 5.54, which again looks like I think it's probably in the green.
Oh,
I mean,
here it is, right
healthy,
here.
yeah. So, and then generally that should be in grams per centimeter squared. I know if it's less than 100 grams per centimeter squared, that's ideal for the visceral adipose tissue. This one looks like it's in inches squared.
Well, here
Um,
they have the green,
Healthy.
the
Okay.
orange, and the
Yeah.
red.
So they
So
calculated
I'm
it
in the
just
ideal healthy.
yeah, so they calculated in inches, squared. So that's where I use a hologic, so it's a different calc,
Mm-hmm.
but that's exactly, it's looking at the volume of the visceral
Mm-hmm.
adipose fat around that area that you can see here. So those are the more validated ones, and that's what I sort of use, to look at.
Yeah. So
But
again,
again, the
for
picture.
people who aren't familiar with visceral fat, can you just break that down real quick?
Yeah, so again, visceral fat is the hormonally sensitive, fat that is around, organs
Right.
or around hips and thighs. So we understand that is like, again, the fat stored in areas that is, causing insulin resistance, is leading to, again, obesity, and really is also concerning for, cardiovascular disease, fat around the heart, for long deposition of time, affecting cholesterol levels. So, we know these things. We know this is again, this is saturated fat around our organs, and is harder to lose. And is also, we know for women, particularly, again, we focus on, menopause is the area where more fat tends to distribute. So this is where we really need to target, our healthy interventions, our resistance exercise, so that, we can literally, this is like, working against ourselves. I always say it's unfair.
Right.
Women have menopause. We know that estrogen, again, is very hormonally sensitive. We know that estrogen receptors are everywhere in our body. And with this sharp decline in estrogen, a lot of things are happening. Metabolism changes, bone changes, genitourinary syndrome of menopause, which is vaginal dryness, changes. Libido issues can change. Things in our hypothalamus in our brain, which is causing hot flashes, insomnia change, joint pains, mood. So we have a lot of things to combat that. There's a whole lecture on hormones and women on hormones, hormone therapy for the appropriate patient that is individualized. And this is what I talk about every single day, day in and day out. We know that hormone therapy is a very effective treatment for many things. We are not there in terms of recommending hormone therapy for prevention of weight loss. We do know that women on hormones through the WHI tend to be leaner. We do know from mixed studies that lean body mass is preserved on women on standard dose hormone therapy, but that has not always been replicated in any large scale studies. So it's hard to say that, but we do know for many women, estrogen without any contraindications can help combat a lot of these menopausal symptoms, as well as shifts that are happening in our body that maybe are silent symptoms of menopause, I like to say.
I would like to add that testosterone is super important for women. While it's not we're not men and don't have a ton of it, it's certainly extremely important, especially when we're having the body composition talk, right? In terms of building that lean muscle mass and the ability to burn fat.
Yeah, so testosterone, I think, right, we gender hormones now, like men have testosterone, women have estrogen, but the reality is we both have all of
Yep.
them, just in different percentages. And now we're having, different, gender affirming surgeries and gender hormones that are being, shared across after surgery and across patients who are transitioning. So I think that is helping us in the world of understanding that,
Yeah.
it's not, one hormone for each sex. What I would say with the testosterone is, we know that testosterone declines after the age of 30. Testosterone can be made in our adrenal glands. It can be made in our ovaries, just like estrogen can be made in different places, our ovaries, our adrenal glands, our fat tissues. And so testosterone, when we look at that we have no FDA approved option for testosterone for women. Hopefully in the next couple of years, I think that will happen. But we do know that we have testosterone replacement for women with low libido. We also know that there's studies ongoing with using testosterone to help prevent falls, to think about replacement and helping with muscle mass and tissue. So I think that will come. We don't have again an option that we can't use, that we can use without compounding that, or what I don't recommend is pellet therapy routinely. So we really are sort of in the dark with the scientific literature and having an option for that is safe and effective and reproducible for women with testosterone. Sure, we know that it can help in certain places. Primarily, again, the indication is for low libido or female sexual dysfunction, but I think over time we'll see more of that.
Yeah.
My caveat with that is women who have undergone surgical menopause, who are very young, obviously we're reducing their testosterone dramatically. And if they don't have a contraindication, I do prescribe testosterone for them, just as I would estrogen replacement therapy. And then the others, it's a nuanced discussion. And I find that many of my women are willing to try hormone therapy, whether estrogen, progesterone, testosterone, with, again, for the right indications, with the right information in front of them.
Absolutely. That's great. I think in Australia, actually, they have a drug out that is available to women for a testosterone boosting drug.
They do. It's called Androfem,
Mm.
Androfemme. You can, so I actually just recently asked them to send me samples. They can't send them internationally. But we used to be able to have them in my old clinic. I think before something happened, they changed it, but that is available. And sometimes I do have patients who, travel or go pick that up, or you can order that online. You can talk to a physician and they will send it to you. And it's based on the fact of, trying to reach a testosterone level that's basically a premenopausal mean
Mm-hmm.
for,
Right.
and so it's not super, physiologic testosterone doses. And that's how I dose my testosterone, based on those ranges. And we almost had a testosterone patch approved here in the United States. Unfortunately, the FDA declined it, but we do have quite a bit of research on use of testosterone in women, just nothing FDA approved.
Yep. Hopefully soon.
Yeah,
Is there anything
agree.
else on this page that we want to go over?
So I think nicely, yeah, I think it's pretty laid out pretty well.
Okay, great. And then this is the muscle mass balance analysis. Anything you want to go through here?
Yeah, I don't see this on mine very often. I mean, again, we're going to see this is maybe more for like, like elite athletes or someone with more, experience on looking at left versus right side, or if you're really trying to train, or if there's been an injury. Sometimes I see patients with that, who've had an injury and they're trying to regain the
Mm-hmm.
muscle mass on that side, or they've had a stress fracture, etc. So I think this would just need to be interpreted with someone who is ordering that and looking at that correctly. Again, is looking at the lean mass, and more we're looking at skeletal mass here than we were how
Yeah.
much fat is in your arm. I think we need to be thinking overall.
Yeah. All right. So let's go back here, and then I'm going to bring up the spine and the femur. So in here, we have a T score and a Z score. So before we talk about my scores, let's just have you explain the
Mhm.
differences between the T and the Z score.
Yeah, and so remember, I just want to remind everyone that this is looking at the total body bone mineral
Right.
density, so not the areas where we actually routinely look, for targeted T and Z score, where this is more validated. So we
Right.
use a total body T score for pediatrics, and sometimes for people who have had a gastric bypass, but really that's where it's validated. And so the T score and the Z score, those are, again, you can see it says here combined NHANES, which is again that National Health and Nutrition Education Survey, which again was 20,000 women and men age 8 to 85. And so we had validated by the World Health Organization and the CDC, looking at what is the mean for women before menopause, what is the mean after menopause. So a T-score is a standard deviation. It takes that BMD, or bone mineral density, that you can see there in grams per centimeter square, and sort of makes it in a more palatable, sort of scientific, explainable and relatable standard deviation from the normal adult mean. And generally, a T-score is comparing someone's bones, particularly women at the age of 30, so someone at their peak bone mass. And so we see derivations from the peak bone mass. A T-score is in generally, from negative 1.1 to minus 2.4 is in the range of osteopenia. Any number hot, above minus 1.1 is considered a normal T-score. As osteoporosis is defined as a T-score of minus 2.5 or lower on a DXA. Again, this has to be done correctly, looking at the appropriate sites. That's one way to diagnose osteoporosis. You can also diagnose osteoporosis from having a clinical fracture, like a vertebral, hip, arm, pelvis, forearm, humerus, or shoulder fracture. That really also means that there's some sort of bone health issue going on, that you could have a diagnosis of clinical osteoporosis, or that makes the diagnosis, I should say. And then a Z-score compares your bones to someone of again, an NHANES database that's been validated. So compares your bone density to someone of a similar age, race, sex, and ethnicity matched. You can imagine that like all of our other health research, most of these are based on Caucasian databases. We have over the years improved our understandings of different bone mineral densities based on different ethnicities, like Asian ethnicities, African American, etc. So the
Mhm.
Z-score, we sometimes have to take a little bit with a grain of salt. When a Z-score is below minus 1.5, or some medical associations say minus 2, that tells us, you know what, your bone mineral density is pretty different than most, people your age, say, sex, race, and ethnicity match. So that means this shouldn't be lower than all these people. So why are you so far up? Kind of like in a test. If you were, if everyone was scoring an 80 and you were scoring 50, we would say, well, why is that going on? So that
Mhm.
means that's a wake-up call, right? That for premenopausal women, we usually report the Z-score. And for postmenopausal women, we report both the T and the Z score, which are, again, both helpful in different ways, but need to be interpreted by someone who understands those results. And I always caveat that the test is done correctly by, a tech, as well as someone reading it who understands how to do DXA and read DXA.
Yep, for sure. Okay, I'm going to stop this one and
Yeah.
then bring up, um, let's see, which page should we bring up? Do you have a preference? Hip,
Nope.
spine?
Doesn't matter.
Okay. We'll do spine. All right, now we have up my spine.
Okay, great. So when we look at the spine, so, again, if we're just going to walk through this, like, let's say you're my patient today,
Yep.
and I'm running right on time. And so what we would look at is we would look at first your name and is your date of birth, and did they actually do a height and a weight that day. I measure everyone on a wall-mounted stadiometer, which isn't just one of those clunky machines that you were measured at when you were, when you were a child. We want to have you take off your shoes, look straight ahead to the horizon, make sure that we're evaluating your height correctly, because height loss is important, because that can be sometimes a sign of either, a fracture, or it can be the sign of arthritis, or we just need to figure out, why are you losing height? Because that also, is important, as we age. Obviously, weight done correctly. And when we look, it's very important, again, that we, we look at all the vertebrae that are in question. So generally, we're looking for lumbar L1 through L4. These are our lumbar vertebrae. These are our load-bearing bones of the body. The reason we use these is, number one, it's sort of out of any of the organ systems that we can't also capture. You can kind of see your lower ribs there on the bottom, but also we know that, again, these are the areas, the thoracic and our lumbar areas are very common areas for fracture. So we can actually evaluate fracture on a bone mineral density. The one thing I would say about your bone density is that those white lines, those like two white lines, so that's your bra, that's your underwire bra. So actually that should be removed, because that can be an artifact in many people's scans. So really underwire any wire. Even I've had patients with like continuous glucose monitors who had to like move over to the side so they're not overlying. This is one of the reasons why we have people not take their calcium supplement or have any radiation, because actually sometimes we can see a little barium or radiation or a calcium supplement on, or a tablet in someone's pocket show up, and that's called like an artifact. So we want to make sure that we don't have any of those artifacts. And we want to be capturing L1 through L4, which it looks like they did correctly in your scan. You kind of can see your lower ribs down at the bottom, and generally we like to see the top part of the pelvis. So and then what we do is, again, we look at each one of the vertebrae. I don't see any, compression of any vertebrae. They look all pretty homogeneous, which is good. You don't have any scoliosis. Many women, I do have many complications, either scoliosis, or they've had spinal surgeries or fusions, etc. So we, or advanced arthritis or fractures themselves. So we really have to look at that scan appropriately. And then we look at the L1, each one of the vertebrae, and then also the T-score between all of them, and then the composite T-score at the end, to make sure that we think that that score is correct and we've correctly assessed it. So your T-score says that your T-score, or your standard deviation from an adult peak peak is minus 1.3, which would, as you can see from the picture, put you right in the range of osteopenia, or we actually medically call that term now low bone mass. So it more aptly discusses what that is. When we look at your Z-score, again, most people just report out the T-score, but your Z-score again shows, yep, you're right on average. You're not too high or too low from, people in your age. I always want to say, thank you for sharing this. And, when we look at bone density, 30% of women will have a low peak bone mass at their time of diagnosis, at their time of menopause, or between their, 50s and 60s. So again, this goes to the fact that when we're checking for bone density at 65, we're checking too late, because we know the incidence in Asian and Caucasian women of having a low bone density or osteoporosis is 50%. So 50% of Asian or Caucasian women who have a DXA will either have osteopenia or osteoporosis before age 65. It's a lot. Flip a coin, I always say. So when patients are devastated about their bone density, I see a lot of people about that. I say, yeah, I know. It's just this is a silent condition of bone loss, and we have to figure out why you have it and what we can do to offset that. We have to rule out secondary causes. So for you, I would talk to you about all the causes and your reproductive, your medical history, your lifestyle, and we would talk about the osteopenia. But I see no fractures. I see your spine straight, and I see that you have osteopenia. And I guess this was your first DXA. So if it wasn't, I would compare it to prior ones, pull up ones from other organizations. We can do something called a cross calibration study, which I do on a daily basis, comparing one scan to another, making sure the region of interest is correct. So this is quite scientific, actually.
Yeah. So then at almost 56 years old for myself, is the T score or the Z score more important? I'm assuming it's the Z score.
Well, no, so it just depends. I mean, if you're still cycling, interestingly, like at perimenopausal, we technically the ISCD, International Society of Clinical Densitometry, says that you should use the Z score. If you're postmenopausal, whatever age that is, like I can have a 30-year-old woman who's postmenopausal because her ovaries are out, we should use the T score.
Hmm.
In the reality, we kind of use both. Over the age of 40, sometimes it's a little bit gray because you can imagine, if we're comparing you to someone of a peak bone mass, why don't we use the T score? But you're still premenopausal, and so
Uh,
we're comparing you to similar age, race, and sex match. So I would say the T score is, what we commonly see, but the Z score is more reflective of, cycling, women. So, and the hardest part is that if we've only reported the Z score up until the time you then become postmenopausal, very many women are confused, right? They're saying, oh, they told me I had a normal bone density. And then after menopause, we use the T score and they're confused about why that is.
hmm.
So both are important and need to be understood. But if you're postmenopausal, even if you're on hormone therapy, we still use the T score.
Mm-hmm. Mm-hmm. Very interesting. All right. Here's my hips.
Okay, so when we look at your hip, the most important thing is, again, we look at, was the scan done correctly? Were the hips lined up correctly? We're getting enough of your pelvis. I would say, and you can probably see this, and now you're going to become an expert in, I'm giving you a fast track on becoming a DXA expert,
Mm-hmm.
is you can see on your left hip, can you see how it's like kind of more, it's like out a little bit. It's not up and down straight, kind of like your right hip is more the femur, the part is a little bit straighter.
Yes.
So
Yes.
this is a little bit externally rotated. So again, that can sometimes influence the results. It can influence the results at the total hip and the femoral neck. So I don't have a pointer, but the femoral neck is the sort of the rectangle box, exactly. And that whole rectangle box all through there is oh, sorry, rectangle. Yeah, the rectangle box
Oh,
is
here.
yeah, that's right. So that's the femoral neck area, or actually
Mm-hmm.
share a screen and do this. And then your total hip is the whole like sort of box around, the whole blue box around, which you can't really see, but the
Mm-hmm.
whole
Mm-hmm.
box around the hip. And so the femoral neck is again an area which has, trabecular bone and cortical bone. It tends to be a little bit lower bone density than the total hip area.
Mm-hmm.
And again, same with the right hip. We scan both hips. Generally, a lot of places only scan one hip. I think that's a detriment, in case you have arthritis in one hip or you need a hip replacement for some reason or you have a fracture. So I generally try and scan both hips if, for good symmetry and information. And then you can see the right hip, your femoral neck is minus 2.4 and total hip is minus 1.5. So you are still just like in the range of just like your spine, your bone densities all sort of correlate. You're in each area, you are in the range of osteopenia or low bone mass. And so that's really important. What's important to know too, though, is you could, let's say your T score was minus 2.6 in your right femoral neck. Well, that actually makes the diagnosis of osteoporosis if we think the scan was done correctly and, everything, all the other, stars were aligned. And so many people are confused because they'll say, wait, they said I have osteopenia here and osteoporosis here and normal here. So which is it? And
Right.
I always say what the recommendation is that we're scanning these small snapshots in time, but remember every bone in our body is made up of a constellation of trabecular bone or cortical bone. So we need to know that, it's not just low in one area, it's low everywhere. So the diagnosis, if you have a T-score minus 2 is really osteoporosis. Now that's not like a death sentence. Okay. This is like, we understand it, we know it, we can figure it out, we can treat it. So again, but it's really important to not just say, oh, it's just osteopenia or, and sometimes reports even will say that, oh, it's
Mm-hmm.
osteopenia in the left hip, osteoporosis in the right. That is completely erroneous. There's one clinical diagnosis that you should walk away with.
That's really good information to know. I actually was about to ask you that
Mhm.
because that is really confusing. It's I guess it's the lowest score, which really is the highest measurement, um,
Right.
is the most prominent and the most important one to look at.
Correct. And we still just like body composition that we just reviewed, that we understand the nuances. Because I'll say to women, many women have a lower spine bone mineral density than they do hip bone mineral density. Or why is the femoral neck a little bit lower than the total hip?
Mm-hmm.
And so we describe like this area of bone is trabecular bone, this is cortical bone. Could there be a little arthritis in the spine influencing the bone mineral density? We know that more bone gets lost through the trabecular compartment, so the femoral neck and the spine through menopause. People who are on steroids, though, are going to lose bone density everywhere. So we still want to understand the nuances of the different sites. And then I don't know if they did the bone quality. Did they do the trabecular bone score on yours? I
Let's
looked at it a
see.
couple of days ago.
There is this page left.
I don't think they
No, then I don't think they
did.
did
Okay.
because this is all I
So
have left.
that's all you have left. Okay. So, and then there's one other test that is, has been around for now a couple years, and it is also validated by the International Society of Clinical Densitometry, and it's called something called the Trabecular Bone Score, or TBS. So this can be on the lunar or the hologic DXA, and it is again done just in the spine. Trabecular stands for again, there's types of bone, but primarily the bone in the spine is trabecular bone, and it looks at the bone quality. So it's actually done at the time of DXA. It's a 2D grayscale image of the quality, or the sort of the best estimate of quality or microarchitecture in the bone. So it kind of looks at a laser focus inside the bone. I kind of say that, if we look at the density, it looks like kind of the outside of the forest. If we look inside the bone and we see that the forest is kind of, dense and nicely separated, or nicely aligned, or there's like sparse, there's holes here, holes there. That's what helps us understand the quality, whether the bone looks sort of more patchy, or it looks
Mm.
more homogeneous. Many women who start menopause have normal bone microarchitecture. We know from the WHI and all the studies that when we look, retrospectively use that data, that through menopause, the bone quality also decreases. And then people with underlying conditions like diabetes, rheumatologic conditions, etc., the bone quality can degrade. So it's really important to look at the density. And then now we can also look at the quality and put those
Mm.
two together and help us better estimate the bone strength. So
It's
it's
amazing.
one thing to be able to be done. I really find that, it's helpful. It's still not, as appreciated, as validated as the density, but it can be sometimes a helpful piece, especially for patients to understand and
Is
help us
there
guide therapy, I should say, and help us guide, therapy and how high of a risk of fracture. We know TBS also independently predicts fracture risk. So
is there an average T score for postmenopausal women or elderly women who fall and break their hip?
yeah, it's a good question. I mean, there's a lot of like data that I'm trying to distill here in a little time, but so here's what we do know. We know that for every T score that declines 10%, so every, 10% of bone mineral density equals one T score. So if we said osteoporosis is minus 2.5, and for every 10% of bone loss, so that means to going from minus 2.5 T score to minus 3.5 T score at 10%, your risk of fracture, particularly hip fracture, doubles. So
Hmm.
it's concerning when women are losing bone density and their T scores decline over time. Or if they come to me and their first initial DXA is a -3 or lower, and they're in their 50s, and I think they're going to live till their 80s, and we're going to decline the bone density over time. That's concerning to me. That is something that we don't want your bones to be someone of it. Bones like it. A lot of patients get confused or upset when they're told, "Oh, I have bones of an 80-year-old when I'm 50." That to me is like not a helpful comment at all. And I would never tell anyone that. And what I would say is your risk of a fracture is as high as someone who has low bone density in their 80s. So we need to, and you're active and doing all this, you're still, and we want 80-year-old women to be active too. We just have a different activity, sometimes expectation for women in their 80s
Right.
for their 50s. So we want them to exercise safely and prevent this bone loss and fractures, because we know that fractures are so common and we can prevent them. The other thing, we know is that when we look at the medical societies, whether that be the endocrine societies, the rheumatologic societies, the osteoporosis societies, and the gynecologic societies, they all sort of agree that people with high risk of fractures are women who are over age 70, less than 10, over age 70, have a T-score of -3 or lower, or I should say, and or have had a history of vertebral fracture, hip fracture, major osteoporosis related fracture like humerus, wrist, hip, all pelvis. So when we look about like to answer your question about who's the highest risk for a hip fracture, how do we know? It's age, low T-score, and prior fracture. And so those are the patients we really, isn't just like talking about calcium, vitamin D, and increasing your resistance exercise. Those are the patients we're understanding why do you have osteoporosis, and we're aggressively treating that osteoporosis so you don't fracture. Like I always tell patients, it's not just to look better on the test. Sure, everyone wants to get better numbers, but it's what's the main outcome.
Right. And if anyone is out there thinking, all right, I'm going to go on a diet and I'm going to drop my 25 pounds and then I'm going to go get this total body composition and the DXA scan, that is not the correct way of thinking.
Correct. Yeah. I mean, sure. I mean, again, I think if the reason why they're doing that, and you're right with the bone mineral, if you lose some weight, when we're carrying around weight in our skeleton, we don't really know the absolute number that affects the skeleton, the weight, but we do know with weight shifts, maybe even up to 10 to 15 pounds, your skeleton is carrying less weight. And so there can be bone mineral density decreases. That's where we're looking at maybe body composition to look at skeletal muscle as well. Oftentimes it's more dramatic, like women or people who go through, bypass surgery and are losing 50 pounds and things like that. We want to be checking again for absorption issues, making sure they're absorbing calcium, vitamin D, but checking their DXAs as well. So it's, it's both, together.
So can you use my data and give me a risk assessment, maybe a 10-year risk assessment, or do you use the FRAX score?
Yeah. So when we're talking about FRAX, I don't know how educated everyone is, but there's a lot of risk calculators out there, just for everything for cardiovascular disease. There's a 10-year major cardiovascular risk. There's, risk calculators for many things. And the FRAX is one that's pretty well adopted here in the field of, bone health. And it's basically, it's been validated by the WHO, and it basically takes all the questions that you're answering in your questionnaire. Remember when you signed up to get a DXA, like when was your age of menopause? Do you have a family history of osteoporosis? What's your height? What's your weight? Are you a smoker? How much alcohol do you drink? Do you have any secondary osteoporosis? Which most of my patients used to say, what the heck is secondary osteoporosis? So anything that we just talked about in the beginning, of any reason that you might lose bone mass that we should capture, like a medical history or medication or a surgical history that might impact bone health. It asks about, if I already said smoking, things like that, and glucocorticoid or steroid use, and all those sort of clinical variables or personal variables. And then you insert your T-score or your BMD of your femoral neck. And again, this helps, sort of gives you a calculation of what's your 10-year predicted risk for major osteoporosis related fractures, so hip, spine, forearm, pelvis, and what's your 10-year risk of a hip fracture. FRAX again has been, it's an online, I should say also online free tool. It's country specific, age, gender specific. It's very helpful. Sometimes my patients bring it to me and calculate it themselves. The strongest risk factor in FRAX is age. So because we know that falls is sort of independently captured in there. So a woman's FRAX score in their 50s and 80s are dramatically different, even if their bone mineral density is the exact same. So you can sort of play around with that, but hopefully that makes sense to. So what I'm saying is, because we know that again, you're higher risk for fracture when you're 80. So your FRAX score is going to always be lower when you're in your 50s. And some women say, well, look, my FRAX score was so low. It doesn't say that I need osteoporosis treatment. But again, we're not talking about treating that fracture. We're talking about primary prevention.
Yep.
So I like the FRAX. I find that I like individualized therapy better. Remember, FRAX was made is based on populations, and to help us guide, who might warrant therapy. But this is a number, we treat people and individuals. So I think it's generally helpful maybe for a screening tool in primary care. If someone has low bone mass or osteopenia and might have an elevated FRAX, we need to be thinking about, therapy or evaluating them. And if it's really low, but you still have osteoporosis, Well, that's erroneous use, right? If you have
Mm-hmm.
osteoporosis, we should treat you. We don't want to just falsely say, well, your risk of fracture now and you're 50 and your risk of fracture and you're 60, but I'm thinking about your risk of fracture in your 70s and 80s. So not so much the 10-year
Yeah.
decade sometimes.
Yeah. For those that are interested, I'll put the website for the Frax tool. I think it's kind of interesting.
Yeah.
So
And yeah,
yeah.
one other thing about Frax is now there's a Frax Plus just to like have updated information. However, it's like requires a subscription and it adds more things because there's some misgivings or caveats, just like every risk calculator.
Mm-hmm.
It doesn't include the spine, and I just explained that the spine bone mineral density can be lower. It doesn't include people with like diabetes, which we know is a really strong risk factor for bone loss and fractures. So it doesn't capture those. So Frax Plus is an attempt to capture more of those
Mm.
things, like when's your last fall, how much steroid have you used? So not just like not just a a yes no nominal answer, but more of a qualitative scan. So it's interesting. I think you get like 5 free that you can do. So I've done it on a couple of patients, and then you have to subscribe,
Oh,
to it.
yeah. Okay.
Yeah.
Interesting. Good to
Yeah.
know. All right. So here we are. I've got my T score. I've got a Y score. I've got all of my scans and, I'm your pretend patient. And so now what? We already in our first podcast episode, we talked about lifestyle. We talked about eating more protein. We talked about getting that sleep, moving every day, doing that resistance training, HIIT training for women is ideal as well. So we talked about these lifestyle interventions, but let's talk about a little bit more for a few minutes on supplements or possible treatment with medication.
So, I mean, I know you're so educated already, but yes, in terms of, if you're 50, 55 with osteopenia or low bone mass. So, and this, let's say this is your first DXA and you're like surprised, I would say common, really common, but not, doesn't need to be normal, doesn't need to be expected. And that's really what I think is, a really big message that we need to share. Many people are very upset by the diagnosis. It's like we can do a lot about this to prevent fractures, right? That's the goal. We want to prevent the fractures. We want to maintain the bone mineral density. So we talk about things like calcium, which we talked about, previously, calcium, adequate calcium in both supplements and in nutrition and in diet, I should say. Appropriate doses of vitamin D. We talked about protein intake. I would measure your balance. I check balance in every one of my patients, either the
Mm,
timed up and go 20-second one leg balance test. I talk about all the different types of exercise that you're doing. So, all right, trying to do resistance exercise, which can include using your own body weight, yoga, Pilates, safely doing these things, looking at, multi variety of different types of exercise. Of course, aerobic exercise. I try and say exactly what I said last time. What's good for your brain is good for your bones, is good for your heart, is good for your mental health. So trying to get in some aerobic exercise, whether that's walking, whether that's classes, whether that's working out at home, YouTube videos. I mean, I now through the COVID pandemic learned so many, and I learned another one today from a patient that you can do and download at home or in a group class or doing something
yeah.
where you are accountable.
No
I always
excuses.
posture and balance.
Mm-hmm.
I say do that easily. Stand on one foot for 20 seconds while you're brushing your teeth, while you're waiting the grocery store line, while you're waiting for your coffee, while you're in the pickup line, something like that. Stand,
Mm-hmm.
practice your balance, challenge your balance. If you're working with a trainer, tell them I want to challenge my balance. I don't want to just do the basics. I want to challenge my balance. I try and do it too. It's hard. I don't,
Yep.
and you get better when you do more. So work on balance because again, we want to prevent a fall. And I always say no medicine, no herbal, no supplement, no botanical is going to prevent a fall, right? So that's really, really important. You're still young in your 50s, but I say this to even women in their 40s. And then we talk about prevention. Again, prevention for osteoporosis, there's not very many FDA approved options. Hormone therapy is one of them that has been known since the 1940s that is FDA approved, that, we know that estrogen prevents height loss, vertebral fractures. We've known that. So I talk about hormone therapy to women who don't have any contraindications, which would be estrogen therapy if you've had a hysterectomy, or estrogen plus progesterone therapy if you have a uterus. And lots of different options and treatments and doses. And I talk about that. There is other options that can prevent osteoporosis, raloxifene, or it's a medicine called a SERM or a Vista, which is also a medicine that can prevent bone loss at the spine and the hip and is used in women who might be or either contraindication for hormone therapy or fearful about estrogen therapy, and it decreases estrogen receptor positive breast cancer in those who have a genetic predisposition to ER positive breast cancer. So that's an option. It's an oral option. There is FDA approved bisphosphonates like alendronate or risedronate that are used at preventative doses. For many of my younger women in their 50s and 60s, they've been prescribed that and not taken that for very many reasons. So we talk about that as an option potentially. Again, for short courses of time, 3 to 5 years is what's generally recommended by the medical societies, and I follow those rules as well. There's even an IV dose of steroids an IV dose of reclast or zoledronic acid that's used every other year for my patients who are at higher risk with osteopenia or low bone mass, who want to be more preventative and who can't take maybe a cadre of the other options. So we really talk about all of those things, and then rescanning in, I generally do 1 year, 2 years if the insurance makes us, but I generally want to say this isn't something that just falls off the radar.
Right, absolutely. What about peptide therapy?
Yeah, I don't know which peptide therapy.
Well, there's all different types of peptides, right? But I was thinking of the one that's BPC. I think it's 157. It helps with lean muscle mass. I don't know if it affects the bone, but we do know that lean muscle mass has a positive effect on bone health.
Yeah, I don't know. This is an area I don't know very much about. I know a lot
Okay.
about the menopause area. And I think here's my problem with I learned about someone the other day, MSM or a different supplement. Patients that
Hmm.
were asking me about collagen. I mean, there are, there are some observational studies, again, studies looking for that, a handful of patients this might be effective for. It's harder to get randomized control studies and things like
Yes.
supplements and et
Yep.
cetera. So we have really good ones on calcium and vitamin D, some things on vitamin K2. I think we're just not there yet in terms of the others. And a lot of patients do get benefit from using some supplements and no harm. The things I get concerned about are things like boron, strontium. These are heavy metals, that deposit in the bone, really not very effective at changing the bone microarchitecture. I wouldn't recommend those. And so
Mm-hmm.
I think I would look, carefully at who's selling me the supplement, why they're selling me the supplement or peptide, and what the research really is behind it. Like we talked about before we started, doing a PubMed research, finding someone in your area
Hmm.
who's, a certified clinical densitometrist, someone through the Bone Health and Osteoporosis Foundation, Menopause Society, who understands some of this literature. And I think some of it is, still evolving, right? So
Absolutely. What about red light therapy? And then we're gonna
I
close
know
up.
you sent me that article too. I mean, I have
Hmm.
had more patients asking me about this. I know that that's, kind of going out there. I really have to wear my science hat here and just say I don't think the jury's out yet. And I really
Hmm.
wouldn't, recommend it.
Yeah, well, I don't think red light therapy is going to hurt anybody. There's so many, I mean, there's thousands of PubMed trials, clinical trials done on red light therapy for other uses for
Right.
mitochondrial function, cellular health. But I am really curious to see where it's going to go in terms of bone health.
Yeah, I don't know if there's any ongoing studies on that. It's something I'll probably have to look up, but I do
Yeah.
think, yeah, I do think that this is an area that just like muscle and strength and things people are paying more attention to. So hopefully that translates into, better, quality research. We know that the Office of Women's Health Research, is sort of funding more high quality research focused on this with the Biden administration, and a lot of the other, players in the women's health sphere now. So hopefully that will translate to,
Mm.
some research in areas that we need. I do think osteoporosis, I think female sexual function is another. I think treatment
Yeah.
of breast cancer, patients with breast cancer with, various estrogens and other is another good area that we need to look into too.
Yeah.
Yeah.
Well, Dr. DeSapri, what a pleasure to have you back on the podcast. And what a special episode we just recorded for everybody. Lots of golden nuggets for people to walk away from. So, when we did
Good.
our first episode, I know you were just getting ready to open up your new clinic. So, tell us a little bit about
Mhm.
where people can find you now. You're open now, correct?
I am open. Yeah,
Yep.
I've been seeing patients since July. It's great. It's so nice to have, an office and a space and a DXA and staff. So I'm in Winnetka. So I'm in 570 Lincoln Avenue. Our office is Bone and Body Women's Health. So I see patients for gynecology, for menopause, for midlife, care. We do DXA here in the office. So I have sort of two options to see patients, either for bone health or sort of for the complete menopause and midlife and beyond sort of discussion, all the things that we talked about here today. And I also see patients virtually. I have quite a big, telehealth, osteoporosis and menopause. Really, a lot of patients are struggling to find local providers or experts, and I really enjoy, talking to patients all across the country. So I have patients now in Colorado and New York, New Jersey, California. So I have a pretty large telehealth practice now too.
Wonderful. That's awesome
Yeah,
to hear. And I'm glad that
yeah.
I'm in the same area as you.
I know.
Sounds like maybe I do need to come see you
Yeah, well,
after,
we talked about yeah,
right, after dissecting my bones.
yeah, but it's good. But this is really what is, again, like required, right? And it's so
Right.
important to know this, because then, again, education, awareness, this is power. So
Absolutely. Well, thank you so much
yeah,
again for joining me. And
thank
we
you.
hope to see you soon.
Okay, absolutely. Thanks, Jill. Have a nice evening.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.